Welcome everyone. In this video we shall be talking about Marfan syndrome and discuss all the questions related to it. So moving on to the first question. Marfan syndrome is most commonly caused by mutation in. Now remember that Marfan syndrome is caused by mutation in the fibrillin gene. Fibrillin 1 gene, and it is inherited in an autosomal dominant fashion. Okay? So FBN1 gene autosomal dominant, yes, this is our correct answer. COL3A gene, this is seen in Ehlers-Danlos syndrome. Fibrillin 1 gene autosomal recessive, this is false because Marfan syndrome is inherited in autosomal dominant fashion. Okay? And TGF beta mutation is seen in Loeys-Dietz syndrome. In Loeys-Dietz syndrome, we might get certain Marfanoid features, but this is not Marfan syndrome. Okay? Moving on to the next question. Which mechanism best explains the pathology of Marfan syndrome? Now remember in Marfan syndrome that there is FBN1 gene mutation. As a result of which there will be a defective fibrillin formation. This defective fibrillin leads to decreased microfibril formation. Microfibril is responsible for sequestration of TGF beta. Now this decreased microfibril will result in decreased sequestration of TGF beta. Which will lead to increased TGF beta. And this increased TGF beta is responsible for abnormal elastic fibers. Okay, so our answer should be fibrillin deficiency causing an increase in TGF beta activity. Yes, this should be our answer. Autoimmune elastin destruction, that's a false statement because there is no autoimmune relation in Marfan. Abnormal collagen 3 synthesis. Is seen in Ehlers-Danlos syndrome. The matrix metalloproteinase deficiency might play some role in Marfan, but majority of its defect lies in the mutation or deficiency of fibrillin. Okay. Moving on to the next question. Which are true regarding Marfan syndrome? Dominant negative FBN1 mutations are more severe. In dominant negative FBN1 mutation, there is complete absence of fibrillin, right? Of course, if the fibrillin protein is completely absent, the severity will be very much high. Whereas in haploinsufficiency, there is decreased fibrillin. Some amount of fibrillin is still left, so we would get mild disease. That's also a true statement. In TGF beta receptor mutation cause Marfan-like syndrome, that's a true statement. In Loeys-Dietz syndrome, we do get Marfanoid features. Right. So that's a true statement. Gene locus is on chromosome 17p. That's a false statement. The gene locus is in 15q. For Marfan syndrome, the gene locus is in 15q. So the answer should be A, B and C. B should be our answer. Okay. Moving on to the next question. The most characteristic skeletal features of Marfan syndrome. The most characteristic skeletal feature is arachnodactyly. Long, slender, spider-like features will be seen. Spider-like fingers. So arachnodactyly, we get long, slender, spider-like fingers. Right, this is the most characteristic features. Now besides that, other skeletal features that can be seen in Marfan include a tall stature. We have a tall stature, and that is disproportionate. Right, where the lower limbs are much more than that of the upper limb, and this is known as dolichostenomalia. Right, I'm sorry. Stenomelia. Okay. Besides that, we get pectus carinatum, we get pectus excavatum, right? Besides that, we can get scoliosis. We get hypermobile joints. Besides that, we can get high arched palate, right? A lot of other skeletal features can be seen in Marfan syndrome. Fine, but the most common one is arachnodactyly. Okay. Moving on to the next question. A 19-year-old tall female presents with myopia, recurrent lens dislocation and retinal detachment. The following features are also evident in the patient as shown in the image below. What is the most likely direction of lens subluxation? This is known as the Steinberg. This is known as the Steinberg thumb sign. This is known as the Steinberg thumb sign, and this is known as the Walker-Murdoch. The Walker-Murdoch wrist sign. The Walker-Murdoch wrist sign, like this, right? I cannot show you. In Walker-Murdoch wrist sign, right? You can completely encircle your wrist like this, right? For some reason, you can see this in me, right? So these two things are very much characteristic of Marfan, right? And moreover, myopia, recurrent lens dislocation, tall female, everything is suggestive of Marfan. Everything is suggestive of Marfan syndrome. In Marfan syndrome, what is the direction of subluxation of a lens? It is superotemporal. It is superotemporal, that is upwards and outwards. So it is up and lateral. B should be our answer. There is a strong differential which is homocystinuria, where we get inferonasal displacement. Where we get inferonasal displacement, which is downwards and medially. Right? We would get downwards and medial displacement in homocystinuria, which is a differential for Marfan. Okay. Moving on to the next question. A 26-year-old Marfan syndrome, a 26-year-old with Marfan syndrome develops sudden tearing chest pain radiating to the back. What is the most likely cause? If we get a sudden tearing chest pain, this is almost always an aortic dissection, and moreover, Marfan syndrome has a very strong association with aortic dissection. Rather, in Marfan syndrome, the most common cause of death is aortic dissection. Okay. So our answer should be okay. And if you have to select between type A and type B, it should be type A. Type A is associated with both Marfan and hypertension, whereas type B is almost always due to hypertension or atherosclerosis. Okay. And remember another few important things, that in type A we almost always, or rather always, have to go for an emergency surgery, whereas in type B we start with beta blockers. Okay. MI from coronary artery disease, we do not get tearing chest pain radiating to the back. It doesn't radiate, it rarely radiates to the back, and we get a compressive squeezing pain. You get a squeezing pain, right? Something is compressing on our chest. And in pericarditis, we get a stabbing pain. In pericarditis, we get a stabbing pain. So answer should be aortic dissection, and that too type A. Okay. Moving on to the next question. A disproportionately tall patient presents with long slender fingers and subluxation of the lens. What is the next most important evaluation? Now from over here it is clear that the diagnosis is likely to be Marfan syndrome, and in Marfan syndrome the most common cause of death is aortic dissection or aortic rupture. So we need to monitor our aortic root. So the most important evaluation should be echocardiography for aortic root dilatation, and we check the Z score. Okay. Serum homocysteine is not done. It is used for homocystinuria. Slit lamp examination is used for subluxation, but the question already mentions about subluxation. Why should we perform it again? And DEXA scan is also not required because it is required for osteoporosis, and osteoporosis is not seen in Marfan. Okay. Moving on to the next question. Which major finding confirms diagnosis without genetic testing? Diagnosis of Marfan. I'm so sorry. It should be diagnosis of Marfan syndrome without genetic testing. Yes. Now, if two clinical features are present simultaneously, then we can diagnose it to be Marfan syndrome even without our fibrillin mutation, even without checking for fibrillin mutation. Those two are ectopia lentis. One is ectopia lentis. The second is aortic root dilatation or aortic dissection or dilatation. Right. So our answer should be A. Now this is an exception to the Gens criteria. Which is the diagnostic criteria. Right. We have a Gens criteria. Which is used for diagnosis of Marfan. Right, based on clinical features and genetic mutation. But even if we don't go for genetic mutation, don't check genetic mutation, if these two clinical features are present, then we can mark it as Marfan syndrome even without fibrillin mutation. Okay. Moving on to the next question. Which contribute to the systemic score of Marfan syndrome? The systemic score of Marfan syndrome is based on this Gant's criteria that I mentioned, Gant's criteria. Now, as per the Gant's criteria, if we have the wrist or thumb sign as mentioned, the Steinberg and the Walker-Murdoch sign. If the wrist and Murdoch sign are present simultaneously, then a score of 3. If both are present, now, and then if both are present, then a score of 3 is given. If any one of them is present, then a score of 1 is given. Okay. Then comes pectus carinatum. For pectus carinatum, a score of 2 is given. For pectus excavatum, a score of 1 is given. Then for pes planus, score of 1 is given. And for myopia of more than 3 diopter, a score of 1 is given. Now, if the total score is more than equal to 7, it is diagnostic of Marfan. Right. Oh my God, I'm so sorry. Right, myopia more than equal to 3 diameter, a score of 1 is given, and if the total score is more than equal to 7, then a diagnosis of Marfan can be made. Okay. Moving on to, okay, now let's talk about this question. Okay, contribute. Okay, pectus carinatum, yes, a score of 2. Severe myopia, yes. Wrist and thumb sign, yes. Pes planus, yes. So all of them are correct. So answer option D should be correct. Okay. Moving on to the next question. A thin disproportionately tall patient has intellectual disability and downward subluxation of the lens. What is the likely diagnosis? Now this seems like Marfan, but in Marfan we do not get intellectual disability. In Marfan we do not get, not seen in Marfan. It is not seen in Marfan. Okay, rather it is seen in homocystinuria. It is seen in homocystinuria. Moreover, there is downward subluxation of the lens. In homocystinuria, we get inferonasal subluxation, whereas in Marfan, we get superotemporal subluxation. So the diagnosis over here should be homocystinuria and not Marfan syndrome. Right. This intellectual disability and the direction of lens subluxation differentiates between Marfan and homocystinuria. Right. In homocystinuria, we get inferonasal subluxation of lens. Okay. Moving on to the next question. The most sensitive parameter for monitoring aortic. Involvement, it is aortic root Z-score, as already mentioned. A Z-score of more than +2 is suggestive of aortic root dilatation. Now, absolute aortic root diameter should not be considered because your absolute aortic root diameter depends on the body size. Right? For a larger individual, the aortic root will be larger. For a smaller individual, it will be smaller. So, we should consider the Z-score. Pulse pressure, again, it is not considered as extremely non-specific. And left ventricle ejection fraction not considered because it is for systolic dysfunction. It measures systolic dysfunction. Right. Although we can see systolic dysfunction in aortic root involvement, but again a non-specific finding. Right. Aortic root Z-score is a better marker. Okay. Moving on to the next question. What is the first line drug to prevent aortic complications in Marfan syndrome? Right. It is beta blockers. The first line drug is always beta blockers, and that too non-specific, that is propranolol. What does propranolol do? Propranolol causes decrease in heart rate and also decreases cardiac contractility. Right, and this can cause a decreased aortic wall stress, right, wall stress, right, and this prevents aortic complications, right. Now, AC inhibitors might be used, but AC inhibitors are always added as second line agents. Right. When beta blockers of propranolol are not enough to prevent complications, then we will be adding AC inhibitors, not as a first line agent. Calcium channel blockers are contraindicated because they can increase your aortic wall stress. So they are not used. Again, digoxin is also not used because digoxin is used in heart failure. It has no role in preventing aortic complications in Marfan syndrome. Okay. Moving on to the next question. Indications for prophylactic aortic root surgery in Marfan syndrome. Right. Diameter more than 5 centimeter, yes, that's an indication. Normally if you don't have Marfan syndrome, right, and the aortic root diameter is more than, in a normal condition, aortic root diameter more than equal to 5 or rather more than 5.5 centimeter is an indication for prophylactic surgery. But in a patient who has Marfan syndrome, right, this limit, this lower limit where we perform surgery is reduced to even 4. In sometimes a diameter of more than equal to 4 centimeters enough to perform a prophylactic aortic root surgery. Okay. Rapid growth of more than 0.5 centimeters a year, that's also an indication. Even if it is not associated with Marfan syndrome, then also we have to perform prophylactic root surgery, right? Family history of dissection, yes, this is an indication. And severe aortic regurgitation, again an indication. Right. So our answer should be A, B, C and D. Right. So with this we come to the end of our discussion on Marfan syndrome. If you like this video, consider subscribing to my channel, and thank you for watching.